respected participants and dear panelists, and Professor H.L. Lutfor sir, our teacher, and Professor Abdul Wadud sir. Eid Mubarak, everybody. After Eid, we are again will start our IPDI virtual class. Today's topic is mitral stenosis. It is the most easiest but most complicated, and I think in the exam, when you is the mitral stenosis, you are ready to fail in exam. So be prepared, everybody. I like to request Professor Abdul Wadud, please say something regarding today's class. Sir.
Well, the topic is interesting, and from the point of examination, it's very important, both clinically, from the point of view of X-ray exam or OC exam, or viva voce questions. And it's a favorite of our teachers. And now, Professor Lutfor Rahman Khan, who has been a very recognized, excellent teacher of clinical cardiology and a remarkable echocardiographer, for him this subject is very easy, perhaps, but not for many of us. So we are hoping that he'll be presenting mitral stenosis in a very exam-oriented but in a detailed way that will make us really understand the whole thing and prepare ourselves for every considerable question that any examiner can ask. And as well as it will enrich our basic knowledge about mitral stenosis. Without much ado, I'm requesting Professor Lutfor Rahman Khan sir to start his class.
Thank you very much, Professor Abdul Wadud Chowdhury and Dr. Mohsin. Assalamu alaikum, Eid Mubarak, and good afternoon to you all. Our today's lecture is the continuation of the last class. My topic was valvular heart disease, and on the first class, we talked about mitral regurgitation, and our today's discussion is on mitral stenosis. So the mitral stenosis is very easy subject, but I have also tried to make it very easy, but it is very important in our clinical life as well as for examination purpose. Then what is mitral stenosis? In short, it is the obstruction to left ventricular inflow at the level of the mitral valve due to structural abnormality of the mitral valve apparatus. Now, what is the components of the mitral valve apparatus? There are 5 components of the mitral valve apparatus. Number 1 is annulus. Number 2 is 2 unequal mitral leaflet, chordae tendineae, and 2 papillary muscles, lateral and medial, and also the adjacent left ventricular muscles are also included in this. You can see here the atrioventricular group. There is a ring. This is the annulus of the mitral valve, anterior mitral leaflet, posterior mitral leaflet, 2 papillary muscles. This is the short axis at the level of the atrioventricular junction. This is the mitral valve, tricuspid, aortic, and pulmonary. We can see that this is a bileaflet valve, a large anterior with short base and a small posterior with wide base. This is the mitral valve with 2 leaflet. Now, etiology of the mitral stenosis. The most important cause of mitral stenosis, at least in developing countries like Bangladesh, is the rheumatic fever. It is the most common cause, and there are some non-rheumatic causes. Among them, the most important is degenerative severe mitral annular calcification, congenital mitral stenosis, that is parachute mitral valve is very important, left atrial myxoma. These are not true mitral stenosis, but they are signs and symptoms mimic mitral stenosis. There are less important causes, mitral post-mitral calcification, and so and so. Now, pathogenesis. In short, I want to say that group A beta hemolytic streptococcus causes sore throat, and from this sore throat there is acute rheumatic fever followed by carditis and valvulitis. This inflammatory lesion is healed by fibrosis. And what are the sites where this occurs? Number one is the mitral cuffs or mitral leaflets. There is fibrous thickening, shortening, and retraction of the leaflets. There are commissural fusion causing narrowing of the primary orifice. In the short axis view, we can see fish mouth appearance, and in long axis, parational long axis view, we can see the diastolic doming of the anteromitral leaflet. In the chordae, there is also fusion, thickening, and retraction that causes the secondary orifice narrowing. There are some important points. Number one is less than 3% of streptococcal sore throat causes only acute rheumatic fever. And there is a rule of 50. More than 50% patients suffer from carditis clinically, but echocardiographically, more than 80 to 90% patients suffer from carditis. And 50% carditis patients develop rheumatic heart disease, and 50% of patients give no history of rheumatic fever. And it is very interesting that mitral valve is affected in more than 90% of cases. Then the aortic valve, tricuspid valve, and very rarely the pulmonary valve. Now, pathophysiology. We know that normal mitral valve area is 4 to 5 square centimeters. When the mitral valve area is less than 50% of the normal area, or it is less than 2 square centimeters, it is mitral stenosis. We know everybody that in diastole, left atrium and left ventricle function as a common chamber. Stenosis, a gradient develops across the mitral valve. Left atrial pressure exceeds the left ventricular pressure, and there is gradual increase in mitral stenosis as it worsens. Retrograde transmission of left atrial pressure in the pulmonary capillary system causes pulmonary congestion, interstitial edema. Pulmonary venous hypertension again causes reactive pulmonary arterial hypertension, right ventricular hypertrophy, and ultimately right ventricular failure. In short, you can see here that this is mitral stenosis, causes elevated left atrial and left ventricular diastolic gradient, elevated left atrial pressure, left heart failure. On one side, there is pulmonary hypertension, right ventricular hypertrophy, right ventricular dysfunction, and right heart failure. And on the other hand, left atrial enlargement causes atrial fibrillation, left atrial thrombus. Clinical presentation or history, with what history the patient comes to us, clinical presentation. If the patient of mild mitral stenosis, it is usually asymptomatic until increased cardiac demand. That is, when there is increased cardiac demand as in pregnancy or after exercise. Usually the patient is asymptomatic in mild MS, but in moderate to severe mitral stenosis, there is dyspnea on exertion initially, and ultimately as the disease progresses, there is orthopnea and PND. In the long run, patient develops pulmonary arterial hypertension, right ventricular hypertrophy, and right ventricular failure, the signs of systemic venous hypertension, as evidenced by leg swelling, that is dependent edema, and abdominal swelling due to ascites. Patient also complains of hemoptysis. It is the most important clinical presentation of mitral stenosis patients. There are two types of hemoptysis. Number one is frank hemoptysis, and another is pink sputum. The pathophysiology differs. In case of pink sputum, it usually we can see in the acute pulmonary edema due to the rupture of the pulmonary capillaries. But after exercise or during more than normal activity, it is the hallmark of finding of severe mitral stenosis. And mechanism: if exercise causes cardiac output to double, there is transmitral gradient will quadruple 4 times, and sudden increase in left atrial pressure causes rupture of the small bronchial and pulmonary venous anastomosis. This is the cause of frank hemoptysis. Other important symptoms are palpitation, which is usually it is due to pulmonary arterial hypertension and right ventricular hypertrophy. Another symptom is Ortner syndrome. There is a hoarseness of voice due to compression of the left recurrent laryngeal nerve by dilated left atrium and pulmonary artery. Physical examination. What are the general examination findings? Most important findings. Number one is mitral phasis. That is pinkish fluid cheeks due to decreased cardiac output and vasoconstriction. It is usually not seen in our country. It is for the white people. We can get peripheral cyanosis due to low cardiac output, dependent edema due to right heart failure, abdominal swelling due to ascites, and tender hepatomegaly due to congestive hepatomegaly. This is the typical finding of mitral phasis in white people. Physical examination, arterial pulse and jugular venous pulse is very important. In arterial pulse, usually the volume is small due to low cardiac output if the stenosis is very severe. But the pulse may be irregular when there is atrial fibrillation. In the jugular pulse, if the patient is in sinus rhythm with pulmonary arterial hypertension and right ventricular hypertrophy, there is a prominent A wave in the jugular venous pulse. But in atrial fibrillation, there is absence of A wave and jugular venous pulsations are irregular. And when there is significant right, and in advanced right ventricular failure, severe right ventricular failure, the patient may show Kussmaul sign and raised JVP. So the Kussmaul sign is specific findings for the constrictive pericarditis, restrictive cardiomyopathy, and severe pericardial tamponade. Palpation of the patient. I always tell to my students that 80% can be diagnosed, patients can be diagnosed by the palpation only. How? If it is typical mitral stenosis, apex bit is usually normally located with tapping in character. What is tapping? It is usually palpable S1, faster sound when it is loud. And there is also diastolic thrill at the apex. In the left parasternal border, we can get some findings which are secondary to pulmonary arterial hypertension and right ventricular hypertrophy. Pulmonary component of the second heart sound will be palpable in the pulmonary area when there is pulmonary arterial hypertension, and there is left parasternal left and epigastric pulsation due to right ventricular hypertrophy. Now, auscultation. Auscultation is done by the stethoscope, but most of you probably know the how stethoscope was invented in the year 1816. It was invented by a French physician. Great man, he is Dr. Linnaeus, a French physician, first invented the stethoscope. There is a short history behind the discovering this stethoscope. Once a patient came to his chamber for consultation. By examination of the pulse of that patient, he suspected that the patient might have some auscultatory finding in the chest. During that time, usually as there was no stethoscope, auscultation usually done by the placing the ear on the doctor, on the chest of the patient, or from the back of the left side of the chest. But unfortunately, the patient was a fair-looking young lady, beautiful lady. So conventional method could not be applied. He thought that how can he auscultate the chest of that patient? He got an idea in his mind, and with that idea, he rolled some papers and make a roll of a paper like a tube, and one end of the paper roll he placed over the chest of that lady and one end on his ear. And he found that the heart sound was intensified, and at that time, this idea, this original stethoscope made of wood, brass, and it was 25 centimeter in length and 2.5 centimeter in diameter. This is modified into a stethoscope of this type in our context. Physical examination, auscultation. Auscultation, we usually auscultate the heart sound and the murmur. The faster sound is louder over the apex. This is the hallmark of mitral stenosis. And second heart sound, its pulmonary component of the second heart sound is loud in pulmonary area. It is the diagnostic of mitral stenosis. Faster sound is the hallmark of mitral stenosis. The opening snap is the diagnostic of mitral stenosis. This opening snap is best heard medial to the apex, in between the apex and the left lower sternal border, with firm pressure with the diaphragm during expiration. Murmur. First of all, I want to say that the length of the murmur correlates better with the severity than the loudness. Loudness is not the factor, but it is the length of the murmur that correlates better with the severity of the disease. In mild mitral stenosis, there is presystolic murmur only, which is absent in atrial fibrillation. But moderate to severe mitral stenosis, we can get the typical findings like low-pitched, localized, mid-diastolic rumble with presystolic accentuation. But in very severe stenosis, mitral stenosis with rigid and calcified leaflet, faster sound and the murmur intensity is soft. This is due to very small orifice and decreased flow across the valve and due to decreased leaflet motion due to calcified and rigid valve. We may get the pansystolic murmur in tricuspid area, which is secondary to the tricuspid regurgitation due to right ventricular dilatation and the dilatation of the tricuspid valve ring. Early diastolic murmur in pulmonary area, which is high-pitched, we can get in severe pulmonary hypertension due to dilatation of the pulmonary artery and pulmonary valve ring. It is known as Graham-Still murmur. There are some maneuvers by what are the things? Patient may be left lateral decubitus position, hard with the veil of the stethoscope. Veil is gently pressed on the apical area, breath held after expiration. If needed, with mild exercise, we can intensify the sound is loud. Second heart sound loud when there is pulmonary hypertension. There is opening snap. There is low-pitched diastolic murmur with presystolic accentuation. Now, investigations. These are the clinical findings, history and clinical findings, symptoms and signs. Now, investigation. Most important bedside investigation is the electrocardiogram, ECG. What we can get in ECG? If the patient is in sinus rhythm, we can get LA enlargement, also right atrial enlargement, and when there is right ventricular hypertrophy, we may get right ventricular hypertrophy, tall R in right precordial leads. But when there is atrial fibrillation, a POF is absent and irregular RR interval. These are the ECG finding of a patient of mitral stenosis. You can see here mild mitral stenosis. There is a bifid P in lead 2 and there is negative deflection in the V1. This is due to left atrial enlargement. If you see this ECG, this is a MS patient, severe MS patient. There is right atrial enlargement, left atrial enlargement with the ECG of a patient of severe mitral stenosis. But we can get also atrial fibrillation in the patient of mitral stenosis, which is very important. RR interval is irregular. There is no P wave. Possibly this patient has right ventricular hypertrophy, though there is no tall R wave in P1, but there is deep S wave in B5, B6, and with right axis deviation, which indicates there may be right ventricular hypertrophy. Chest X-ray. We get a double density along the right heart border due to enlargement of the left atrium. Pulmonary artery segment is full or bulged. It is due to the dilatation of the pulmonary hypertrophy secondary to pulmonary arterial hypertension. We may get curly B lines in the lung fields. This is due to chronic pulmonary venous hypertension and hypertrophy and edema of the lung septum. Upper lobe diversion we can get frequently. It is due to pulmonary venous hypertension. Retrosternal airspace is reduced to right ventricular hypertrophy. It is seen in. We may get mitral valve calcification also. You can see here bulging of the pulmonary artery. We can see the double border at the right heart border. We can see the upper lobe diversion. This is a typical chest X-ray of a mitral stenosis patient. The patient is also female. The female patients are more affected than the male, 3:1 ratio. And here we can see that there is retrosternal air space is reduced due to right ventricular enlargement also. Now, very important is echocardiography. Echocardiogram is essential in the diagnosis and quantification of the mitral stenosis. Now, I will take 1 minute time to introduce two legends in the field of echocardiography. If I don't do so, it will be crime for me. I think it will be crime for me. Great man, he is the father of echocardiography, Professor N.C. Nanda. And possibly, you know this great man also. He is the professor of echocardiography in Bangladesh. He is our direct teacher, Professor Abu Jafar. Echocardiography, first of all, M-mode assessment. In M-mode assessment, we can get the leaflets thickening, calcification, reduced mobility, and leading to decreased EF slope, multiple linear echoes, and parallel motion of the posterior mitral leaflet in relation to the anterior mitral leaflet. There is absent A wave. The characteristics for the mitral stenosis M-mode finding. You can see here the right ventricle, interventricular septum, anterior mitral leaflet, EF slope is reduced, posterior mitral leaflet follows the anterior mitral leaflet motion. In 2D echo, we see the first of all, we see the mitral valve morphology, leaflets thickened, commissures chordae thickened. There is commissural fusion. Assessment of MS severity is done by mitral valve planimetry in short axis area. There is also left atrial enlargement, left atrial thrombus, evaluation of the involvement of the other valves, evaluation of the right ventricular function also we can get by 2D echocardiography. There is diastolic doming of mitral leaflet due to restricted mobility of the leaflet, or also known as hockey stick appearance. There is narrow orifice which is seen in parasternal short axis view. Left atrial enlargement is very frequent. Anteroposterior diameter, if it is more than 40 mm in male and more than 38 mm in female, it is the dilatation of the left atrium. In volume, left atrial volume index is, if it is more than 34 mm per square meter, there is left atrial enlargement. This is curved section of left ventricle, long axis view, short axis view showing the mitral valve orifice. Here you can see parasternal long axis view, dilated left atrium, anterior mitral leaflet tip thickened, posterior mitral leaflet tip thickened. There is diastolic doming or hockey stick appearance of the anterior mitral leaflet. In short axis view, you can see the small orifice, which is fish mouth appearance like. Here you can see the doming of the anterior hockey stick appearance of the anterior mitral leaflet in parasternal long axis view. This is in parasternal short axis view. You can see here the fish mouth appearance of the mitral valve orifice with commissural fusion. Cordia thickened, which is visual, and tip thickened, cordia thickened, left atrium, and right ventricle is not yet affected by pulmonary hypertension yet. Now, planimetry. Planimetry is best correlation with anatomical valve area. By direct tracing of the mitral valve orifice, it is done at its smallest orifice, including open commissures. Open commissures should be included, otherwise it will be underestimated. Including open commissures and in mid-diastole and possibly and preferably in parasternal short axis view, so that calculation is right. Grading of mitral stenosis severity by mitral valve area. When the mitral valve area is more than 1.5 centimeter square, it is known as progressive mitral stenosis. When it is 1 to 1.5 square centimeter, it is severe. And when it is less than 1 square centimeter, it is very severe. Doppler echo. By Doppler echo, we can see two things, important things. Pressure half time. Mitral valve area is calculated by 220 pressure half time. And mean gradient. Mean gradient is the Doppler. If the mean gradient is less than 5 millimeter mercury, it is termed as mild mitral stenosis. If it is 5 to 10 millimeter mercury, it is moderate. And if it is more than 10, it is severe mitral stenosis. You can see here, apical four-chamber view. This is the pressure half time. This is the peak gradient. This is the mean gradient. Calculated automatically by tracing the mitral valve in diastole. Mean pressure gradient is 11 millimeter mercury. And here pressure half time is 235. And by calculation, 220 by 235 valve area is 0.94 centimeter square. Here pressure half time valve area is 0.9 centimeter square. By tracing the mitral flow, continuous wave flow, the valve area gradient is more 16 millimeter mercury. If it is more than 10, it is severe mitral stenosis. Assessment of pulmonary arterial hypertension by 2D echocardiography. There are some indirect measures and some Doppler direct measures by Doppler echocardiography. There will be dilated pulmonary artery. Pulmonary valve motion is very characteristic. There is A deep is reduced or absent. There is EF slope, which is also reduced. And by Doppler, pulmonary artery systolic pressure and mean pressure we can calculate. PSP or pulmonary artery systolic pressure is calculated by peak TR velocity plus 10 millimeter mercury, assuming the mean RA pressure is 10. And mean pulmonary artery, it is the early peak pulmonary regurgitation gradient by continuous wave Doppler across the pulmonary valve. There is a term, Wilkins score. This is used for the evaluation of the patients of mitral stenosis, whether the patient is suitable for balloon mitral valvotomy or PTMC, also known as PTMC. Scoring of the valve, how it is assessed. There are 4 things we have to see. First one is leaflet mobility, leaflet thickening. Reading of Wilkins score is graded from 1 to 4. Grade 1. Severe involvement, the lowest score is 4 and the highest score is 16. A score equal to or less than 8 predicts feasibility of the balloon mitral valvotomy and short and long-term success of the mitral valvotomy. What is success? Success is defined as increasing valve area more than 50% of the pre-dilatation area, or mitral valve area more than 1.5 square centimeter, less than grade 2 MR, and durability is more than a decade or more. This is the grade 1, grade 2, grade 3, grade 4 Wilkins score. We see the mobility, thickening, calcification, and subvalvular thickening. This is the schematic representation: mobility, thickening, chordary, calcification from mild to severe form 1, 2, 3, 4. This is the interpretation of the Wilkins score. If the score is equal to or less than 8, patient is suitable for PTMC and outcome is very good. If it is more than 8 and up to 12, it is can be done. Less favorable, but can be done in some circumstances. I will talk it later on. If it is more than 12, it is contraindicated. Outcome of mitral stenosis. Commonest complications are pulmonary hypertension, right heart failure, hemoptysis, pulmonary infection, atrial fibrillation, thromboembolic manifestations, stroke, cerebral stroke, or peripheral embolism. Now, management, it is very important. Treatment options. we can divide the treatment options into medical management and intervention. Medical management again includes two things. Intervention includes medical intervention, that is PTMC or BMV, and surgical intervention, which includes two things: open mitral commissurotomy and mitral valve replacement. Medical management includes some things. Most important of them are moderate to severe mitral stenosis. But if pulmonary congestion and congestive heart failure, we must use diuretics, beta blockers, AC inhibitor, or ARB and digitalis. If there is atrial fibrillation, we must and also anticoagulation. These are the three principles for the treatment of atrial fibrillation in a patient of mitral stenosis. Now, rate control and to restore sinus rhythm in atrial fibrillation. When it is sudden onset atrial fibrillation, acute onset with fast ventricular rate, patient is hemodynamically unstable. Due to diastolic filling time is reduced, loss of atrial systole, further decrease in left atrial emptying, cardiac output is reduced, left atrial pressure increased, patient develops acute pulmonary edema and cardiogenic shock. To restore the sinus rhythm and to reduce the heart rate, to control the heart rate. But rate control is also done in severe cases, but patient is not in shock. Then rate control is by IV drug like beta blocker, rate limiting calcium channel blocker, amiodarone, and digoxin. But digoxin works less rapidly and preferred if blood pressure is very low. In chronic atrial fibrillation, rate control by oral medication, beta blocker, both at rest and during activity it acts, and digoxin in congestive heart failure, that is right ventricular systolic failure. Anticoagulation. Anticoagulation in mitral stenosis is very important. Usually we use warfarin. INR should be kept in the range of 2 to 3. An indication of anticoagulation in mitral stenosis is very important. It is thrombus, spontaneous echocontrast in the left atrium, past history of thromboembolism, left atrial enlargement, more than 55 millimeter, even in the patient is in sinus rhythm. This is the role of beta blocker in mitral stenosis. This is a beta blocker. Role of antibiotic in mitral stenosis. Penicillin is the drug of choice for the prevention of recurrence of acute rheumatic fever in mitral stenosis patient. It can be given in two ways: oral phenoxymethyl penicillin 12 hourly or parenteral subgluteal intramuscular benzathine penicillin 3 weekly. Duration is lifelong. When there is alveolar heart disease, duration of the antibiotic prophylaxis is lifelong. TMC indication. We can divide the indication into two groups. Number one is symptomatic group, asymptomatic group. This is symptomatic group. When there is favorable valve morphology, Wilkins score equal to or less than 8, and valve area is equal to or less than 1.5 centimeters square. Favorable valve morphology. But we can do this in less favorable valve morphology, that is Wilkins score is more than 8 to 12. When it is done in high risk surgical patient, where the benefit of less than perfect result exceeds the risk. Asymptomatic patient, when we will do balloon mitral valvotomy, for severe MS with favorable valve morphology with high risk of dense spontaneous echocontrast in the left atrium, recent atrial, and hemodynamically, if the patient is pulmonary artery pressure is more than 50 millimeter mercury at rest and more than 60 millimeter mercury on exercise. Pregnancy. These are the indication of PTMC in asymptomatic patients. Procedure. In short, at first, transeptal puncture is performed interatrial septal puncture. Interatrial septum is dilated with a small dilator. Then a sheet is advanced across the septum. A large inner balloon catheter is advanced through the septum and across the mitral valve. Stepwise dilatation causes fracture of the rheumatic adhesion in commissures that increases the leaflet motion and also increases the mitral valve area. Schematic representation, IVC, right atrium, interatrial septum, balloon is depleted, balloon. You can see here, septal puncture, then dilatation of IAS with dilator, balloon inflation creating a waist at the site of the stenosis and full balloon dilatation. What is the result? Mitral valve of initial area and usually valve area is more than 1.5 centimeters square. Decrease in transmitral gradient, cardiac output increases, pulmonary artery pressure also reduced. What is successful PTMC? It is usually achieved in more than 80% of patients. It is defined as valve area more than 1.5 centimeters square, no mitral regurgitation or less than mild mitral regurgitation. Valve gradient is reduced. It is durable for a decade or more. There are some important complications of PTMC: stroke, significant mitral regurgitation, cardiac perforation, cardiac tamponade, and ASD. What are the important contraindications of PTMC? If the mitral valve area is more than 1.5 centimeter, it is the important contraindication. Absence of commissural fusion. We usually split the commissure. If the commissures are not fused, there is no indication of PTMC. If there is more than mild mitral regurgitation, severe bicommissural calcification, severe concomitant aortic valve disease, or severe tricuspid regurgitation or tricuspid stenosis. Concomitant coronary disease requiring CABG, left atrial thrombus, and high Wilkinson score. These are the contraindications of PTMC. Balloon mitral valvotomy. Some important tips. Balloon mitral valvotomy does not split the chordal fusion. So if there is subvalvular stenosis or secondary stenosis, if there is no commissural fusion and if there is significant subvalvular involvement, PTMC is not indicated. Left atrial thrombus. If there is left atrial thrombus, anticoagulation with warfarin for 3 months. Then, if no thrombus on transesophageal echocardiography, PTMC may be done. This is the chart. Severe mitral stenosis is symptomatic, with symptom, without symptom. I have mentioned this thing. This is in short. This is the guideline which I have mentioned earlier. You can see here, if you are looking lady with bulged abdomen, don't think that he has right heart failure and ascites or hepatomegaly, but mitral stenosis with pregnancy. As the mitral valve disease mainly affect the female, so mitral valve disease, especially mitral stenosis, is very common in mitral stenosis female patient. Then there are some pregnancy issues and mitral stenosis. What happens? Severe mitral during pregnancy, blood volume is increased. We know that a transmitral gradient increase several folds from the second trimester onward. Cardiac output is decreased, left atrial volume and left atrial pressure increases, there is pulmonary congestion. We know that the symptomatic status follows the rule of one class. That is, if the patient is asymptomatic before pregnancy, he will develop grade 2 class NOSA. And if initially he was class 2, he will develop class 3 symptom in pregnancy. Symptoms reaches their peak at 20 to 32 week gestation. Risk remains during labor and delivery also. Due to increased venous return and increased blood volume, as a result of uterine contraction during labor and autotransfusion of venous return from the lower extremities after delivery due to relief of heavy uterine compression on pelvic veins. Indication of medical therapy in pregnancy. Symptomatic and clinically significant pulmonary hypertension, that is, pulmonary artery systolic pressure is equal to or more than 50 millimeter mercury. How to follow up a pregnant lady with mitral stenosis? If stenosis is mild, every trimester prior to delivery should be followed up. But if a moderate to severe MS patient should be clinically and echocardiographically should be followed up at least monthly or bi-monthly. Medical therapy. Moderate to severe mitral stenosis patients with pregnancy, there should be restriction of physical activity and selective beta blockers, preferably metoprolol or bisoprolol can be given. Diuretics is given when there is pulmonary congestion. Anticoagulation when indicated with heparin or warfarin. All patients with significant mitral stenosis patients should be counseled against pregnancy. Now, the question of intervention, where we will go to do the intervention. Pre-pregnancy period, PTMC is preferred. Intervention is recommended before pregnancy in patients with mitral stenosis and valve area is less than 1 square centimeter. This is class 1 indication, or valve area is less than 1.5 square centimeter. This is class 2A indication. During pregnancy, what we will do, if the patient class 3 and 4, PTMC should be done, and or pulmonary artery systolic pressure equal to more than 50 millimeter mercury despite optimal medical treatment and in the absence of contraindication. Timing of PTMC is very important. It is usually asked in the examination. We must know that the PTMC is preferably performed after 20 weeks of gestation. And technical aspects, there are some technical aspects. Minimal fluoroscopy use, echo guidance is preferred. Stepwise dilatation, management during labor and pregnancy. Vaginal delivery is preferred in mild MS patient. 1, 2 without significant pulmonary hypertension. In this case, second stage of the liver should be shortened by assisted vaginal delivery. Cesarean section, where you will do that when the patient NOSA class 3, 4 have significant pulmonary hypertension and PTMC cannot be done, is not available or has failed. Surgery should be done. A PTMC contraindication. Anticoagulation in pregnancy is very important. It is recommended in mitral stenosis patient with atrial fibrillation, whether it is paroxysmal, persistent, or permanent. If there is prior history of embolic event, left atrial thrombus, left atrial diameter more than 55 millimeter, even in sinus rhythm, and there is spontaneous echocontration to the left atrium. Anticoagulation in pregnancy is very important. I have mentioned it earlier, but how it should be done? Warfarin use is contraindicated during first trimester because of the risk of embryopathy, and it is usually not used in the last 2 to 3 weeks due to bleeding risk during labor. Anticoagulation protocol. First trimester, we must give the heparin. Second trimester, up to 36 weeks, warfarin, and from labor, again heparin, and INR should be kept in a range of 2 to 3. Mitral stenosis and concomitant valve disease, other valve disease. Most common combined valve lesion is mitral stenosis and mitral regurgitation. It is invariably asked in the examination that if there is combined mitral stenosis and mitral regurgitation, which one is the predominant lesion? Left ventricular remodeling gives the best clue regarding which lesion is predominant. If LV is dilated, mitral regurgitation is the predominant lesion. And if LV remains normal in volume, MS is predominant. Aortic regurgitation is the next most common accompanier of mitral stenosis, but AR severity is underestimated by clinical and echo evaluation. Indication of surgery. Symptomatic patients, NYSA class 3 and 4. There are two procedures for the routinely practiced in our country, all over the world. One is open mitral commissurotomy. Usually, closed mitral commissurotomy is not done nowadays. But initially, when we were a student, PTMC was not available. Invariably, CMC was done, but now it is open mitral commissurotomy is frequently done. Mitral valve replacement is the second option. Hope for the green field and blue sky again. Thank you all. Be safe and stay well.
Excellent. Excellent. Thank you, sir.
Welcome. Welcome.
Now, Mohsin. Hello, Mohsin. You can take over the question answer session, whether the for the participants, if you follow the lectures, I have segmented in different ways. Actually, in each segment, there are questions that we potentially ask. And he has presented his lecture in such a way that, as I was saying, almost every conceivable questions are answered in his lecture. So if you can actually learn from this lecture, nobody can make you embarrassed during exam, and your knowledge will be. Any comment from Dr. Khalid Mohsin bhai?
Thank you, sir, for your very nice presentation. And we learned mitral stenosis from you. Electrocardiogram in rheumatic fever project, we used to go there, and you demonstrated to us directly. So I just want to just clarify a few points what sir has said. I don't have any question. Actually, the rhythm control actually in atrial fibrillation of mitral stenosis is usually not very successful due to the increased size of the left atrium. So we should not attempt to control the rhythm, and it is usually unsuccessful. We must concentrate on rate control. So amiodarone and other drugs should be better avoided. And rate control, for rate control, it is better to use digoxin and beta blockers. And we all know that we have to avoid the use of vasodilators because it is stenotic and already the cardiac output is low. So in case of significant mitral stenosis, it is better to avoid the vasodilators as much as possible. Sometimes we are using the vasodilator beta blocker. This is also not very much recommended. But anticoagulants, we must re-emphasize that the NOACs are not indicated. Some people are using the NOACs and some are using only aspirin. These are not within the guidelines, and sometimes these are harmful for the patients. So we should refrain from doing these things. And regarding the pulmonary hypertension of vasodilators like sildenafil, cardiologists are using it. I should emphasize that please don't use this type of drugs. And other thing, the infective endocarditis, we all know mitral stenosis is not a very high risk lesion for infective endocarditis. It's of an intermediate risk lesion. Not be very much concerned, but if we don't sterilize the balloon properly during PTMC, a lot of patients do get infective endocarditis. The sterilization of the balloon by the chemical methods, it is of very utmost importance. Thank you so much for your attention.
Thank you, Professor Mohsin.
Sir, one question of dyspnea in MS patient.
In mitral stenosis, there is a gradient across the mitral valve. Left atrial pressure is always pressure. This is retrogradely spread to the pulmonary vein.
Mostly there is sound disturbance.
When there is pulmonary causes, tension and interstitial edema, pulmonary congestion, and patient gets shortness of breath, initially on exertion and later on orthopnea and PND. It is
Exactly.
Sir,
Another question is, why pre-systolic action? Khalid bhai, do you want to?
Yeah, just I want to have a question to sir. What are the changes in the auscultatory finding after a PTMC? You sometimes ask in the examination, but you haven't answered PTMC and after PTMC. What are the difference in auscultatory finding?
Or rather, actually, sir, we asked the question: how can you be sure clinically your PTMC has been successful?
Yeah.
Clinically.
Yeah.
Yes. The duration of the murmur will be reduced fast, and if it is valve area is greater than 1.5, 1.8, then there is only loud faster sound, but there is only pre-systolic accentuation, mid-diastolic murmur duration is reduced. And in the long run, pulmonary hypertension feature is reduced because the pulmonary hypertension of the mitral stenosis is easily reversible.
Another thing is that patient often tells that just after PTMC, successful PTMC or very tight MS, they feel the chest is a little bit light.
Clinically, patient will feel
Clinically, patient feels better. And another thing is that sometimes the blood pressure, systolic pressure, a little bit later comes up a little bit more. If it was 110 before systolic, then it becomes 115 or something like that.
It is due to increased cardiac output.
Increased cardiac output.
Thank you. Before Dr. Sanjida answering, do you hear me?
Yes, sir. Yes, sir.
Yeah. Please ask a question. Dr. Sanjida, you ask a question.
Yes, sir.
Okay.
Sir, thank you for giving me the opportunity to ask a question. So I have two questions to you. Firstly, 26-year-old female diagnosed case of severe mitral stenosis with moderate aortic regurgitation with spontaneous echo contrast in LA. Wilkins score is 8. So what will be the treatment strategy in this case? Is it a resolution of spontaneous echo contrast followed by PTMC and follow-up for aortic regurgitation, or do we undergo dual valve replacement? And if we do the dual valve replacement, which valve should be replaced first, at mitral or at the aortic area? And the secondly, sir, the second question is, what will be the treatment of pulmonary hypertension in case of mitral stenosis?
Okay.
Sir.
Your first question, okay. So,
Yes, sir. Yeah.
First question is, there is spontaneous echo contrast. When there is spontaneous echo contrast in a patient of mitral stenosis, there is indication of warfarin, anticoagulation. This is the first thing. But when there is severe mitral stenosis with moderate aortic regurgitation, I have already mentioned that in case of mitral stenosis, the aortic regurgitation is underestimated. By balloon valvotomy, then grade 3 aortic regurgitation will be increased into grade 4, and patient will develop acute pulmonary edema due to heart failure on the table. So the treatment of choice is open mitral commissurotomy with the valve replacement, aortic valve replacement. If possible, open mitral commissurotomy, that is repair of the mitral valve, and aortic valve replacement. But keeping the mitral valve in hand, if necessary, if needed, mitral valve replacement can also be done if the valve morphology is not satisfactory. And you have another question: which valve should be operated first? It is the mitral valve, then the aortic valve.
Regarding
Mitral
mitral
valve
hypertension,
first, then the aortic valve.
regarding pulmonary hypertension, what is the management of pulmonary hypertension?
Regarding pulmonary hypertension,
Management of pulmonary hypertension.
according to guideline, if there is significant pulmonary hypertension due to hemodynamic derangement, there is a indication of mechanical relief of the mitral stenosis, either by PTMC or by surgery. So, long-term treatment of severe pulmonary hypertension will worsen the patient's symptoms. We should early do the intervention without treating the pulmonary hypertension.
Thank you.
Can I put something?
Yes, sir.
Even in severe pulmonary hypertension, if you open up the mitral valve gradually down to near normal level.
Yeah,
Surprise.
it is reversible. I have mentioned.
Just imperatively we should go for mechanical relief of the problem. So my question is that in Western countries, mitral stenosis often presents in late life. That's not very common in our country. That is patient very early on. Can you elaborate on that?
What is the question? Please.
Western world, some residual mitral stenosis, or as in case of USA, due to some outbreaks of limerick fever again in the late 18s, they have some mitral stenosis patient, but these patients present much later. In our country, we get patients very early on, 10 years, 12 years, 15 years patient coming with severe mitral stenosis. They do not have in those countries. What is the difference? Why is that difference?
Oh, yeah. In our country, due to poor hygiene and poor patient, so it is the number of recurrence that causes early development of mitral stenosis. Initial attack, when there is initial attack of carditis, if there is subsequent attack of rheumatic fever, the patient will develop definitely carditis second time, third time, and on. So when there is several recurrence of rheumatic fever, mitral stenosis will be developed earlier than the Western country. They are health conscious. They are also risk man. They can take antibiotic. They can, which is absolutely impossible in our country, in our context. This is the important cause.
Thank you. Another question, Dr. Shudhir. Dr. Shudhir,
Yes,
yeah, you ask your question.
Assalamu alaikum, sir.
Shudhir.
Yes, sir. Assalamu alaikum, sir.
Yeah.
And thank you very much for the brilliant presentation. I always find your lectures very amazing, sir, and you very nicely.
You are from? Where are you from?
Yeah, I'm from Nepal, sir.
Nepal. Thank you so much. Yeah.
And the most important thing, sir, I would like to mention is I would like to know that how you keep yourself so young and energetic, sir. Sir, in one of the slides you have mentioned of mitral stenosis develops severe
Sound, please.
Yeah. Network problem. Hello, Dr. Shudhir.
We cannot hear you.
Dr. Shudhir.
Dr. Shudhir. Unmute your.
We just wait for him. Dr. Fazila Malik, madam, with us. Madam, do you hear me?
Hi, so thank you for the brilliant presentation. Walaikum salam. Thank you. Really enjoyed your presentation. Great presentation as usual. And I would like to congratulate Wadud and Mohsin for taking this initiative. So many people will benefit from what you're doing. And I'm so grateful that you took this initiative. Great work, and keep it. Like publish it also. These small questions, like the whole transcript, You're recording it, I know, but you know, like if we have a book 6 months down the road, which would really help the examinees, I think, right? So many vital things are being discussed here. So congratulations.
Thank you, madam.
Thank you.
Dr. Sudhir, do you have?
Yes, sir. I got disconnected for the intervention.
Okay.
According to sir, hemoptysis was a feature of severe mitral stenosis. But we
Yeah.
know that when a patient will develop severe mitral stenosis, the patient will consequently develop pulmonary hypertension. And frank hemorrhage can be an early feature in 10% of the cases. So as the patient will develop pulmonary hypertension, this hemoptysis will eventually disappear, and even the dyspnea. And then the patient will present with features of pulmonary arterial hypertension like fatigue, chest pain, and also the features of right ventricular failure, that is the leg edema. So can you please make clear of this, sir? This was one question. And the second question is, what is the hallmark finding in case of mitral stenosis in echo, sir? Because there are a lot of findings. Thickening of the leaflets and fibrosis, subvalvular apparatus changes. So
Okay.
what's
Okay,
the
yeah.
important?
Okay, thank you.
I will give you
Please
answer of the last question first.
Yeah.
Echocardiographically, if there is commissural fusion, this is the hallmark of the mitral stenosis, and other important associate findings are thickening of the leaflets and chordae, and it is the tip of the leaflets and the chordae that are involved. But it is the commissural fusion and calcification which is the hallmark of stenosis. And your first question, yeah, when there is pulmonary edema, there is hemoptysis develops, and the hemoptysis of pulmonary edema is usually pink for this sputum. This is typical pink for this sputum, and never it is frank hemoptysis. But when the patient develops vasoconstriction, pulmonary vasoconstriction, and there is reactive pulmonary arterial hypertension, ultimately this type of symptoms of pulmonary heart failure. But the frank hemoptysis, mechanism of frank hemoptysis is due to the rupture of the small bronchial and pulmonary vein anastomosis. It is usually occur in case of severe mitral stenosis with severe physical activity. And this is the important finding, which is pathognomonic finding of mitral stenosis patient, the frank hemoptysis, where there is rupture of the small bronchial and pulmonary vein anastomosis after exercise. This is specifically, this is the important finding for mitral stenosis, severe mitral stenosis patient, which is not usually found in other cases. Usually, this is the most common in mitral stenosis with frank hemoptysis.
Thank you,
Sorry.
sir. Thank you.
Can I
do something?
Anything
Can I
else?
do something?
Yeah, sir. Wadud, sir, please.
Another case of hemoptysis, those is a R1 anticoagulation. If they do not keep the INR low, within limit, sometimes they may have hemoptysis. But usually those are never as severe as those bronchial and pulmonary venous anastomosis.
Okay, Dr. Aziz. Dr. Aziz, do you hear me? Aziz, you to help? Dr. Aziz. Dr. Aziz Sohail, do you hear me? Dr. Bhavani Logan.
Hello, doctor.
Yeah.
Okay, doctor. I'm Dr. Kavin. So I have a couple of questions here. So the first thing is, should we routinely give prophylaxis against rheumatic fever and infective endocarditis in all patients of mitral stenosis? The next question is like, after what age we should think of this? And other than longer duration of murmur, what are the other clinical signs of severe murmur? And in rheumatic fever, how does the valvular agitation to mitral stenosis? normally will be mitral regurgitation. So how does it progresses from mitral regurgitation to mitral stenosis? So these are the questions.
Okay, thank you, doctor. Your last question is initially there is mitral regurgitation when there is carditis, but patient develops later on a mitral stenosis. How it is? What is the mechanism?
Yes.
This is very important. I mentioned it earlier in my lecture in one slide that initially there is myocarditis or pericarditis. When the endocardium is involved, patient may develop systolic murmur, even mid-diastolic murmur, which is known as caricum murmur due to swelling or edema of the leaflets. But systolic murmur is very common, but ultimately patient develops mitral stenosis. How it is possible? It is possible due to there is inflammatory process in the valve, endocardium, which is surrounding the valve leaflet, enveloping the valve leaflet. These gradually there is fibrosis of the leaflet, there is shortening of the leaflet, and there is also thickening and fibrosis of the subvalvular apparatus like chordae tendineae, even papillary muscles. And the most important thing, which is the commissural fusion, which is the hallmark I have mentioned earlier, which is the hallmark of mitral stenosis, is the commissural fusion. When there is commissural fusion, the man-mouth appearance of normal mitral valve is converted into fish mouth appearance or buttonhole appearance. Stenosis. And second thing, the duration of the murmur. If I am not wrong, you have asked me the duration of the murmur, why it is important due to severe mitral stenosis. Because it is loud, faster sound, or loud murmur is not the hallmark. It's not the diagnostic point of severe mitral stenosis, but it is the duration of the murmur. When there is severe stenosis, left atrium tries to contract for a long time to expel its blood through the narrowed mitral valve to the left ventricle. So there is the duration of murmur is very prolonged. It is the duration of the murmur and not the loudness of the murmur.
Okay.
Thank you. Dr. Saiful Islam, sir, with us.
Can I say something, sir?
Yes, sir.
Actually, the systolic murmur that we get in acute ischemic fever is due to carditis, not due to valvular. Get the caricus diastolic murmur.
Diastolic murmur, yeah.
The systolic murmur is due to carditis, due to ring dilatation. And that actually carditis gets in. So that is absent, and the fibrotic change that's in that leads to the mitral stenosis. The second is
We cannot hear you, Professor Wadud. Unmute.
Unmute, please.
Unmute, please. We cannot hear you.
Sir.
Can you hear now?
Yeah, now it's clear. Yeah.
Hello?
It is.
Yes, sir. Yes, sir.
We can hear you.
The duration of the murmur and the distance between second heart and optic nerve, these two are the factors that can actually determine the severity of murmur. Actually,
not the intensity, yes.
Dr. Saiful sir, principal of Khaja. Yes. Dr. Saiful sir with us. Sir, please add something or something, please.
Thank you, Dr. Mohsin. Can you hear me?
Yes, sir. Yes,
yeah, we can hear you.
Thank you. Assalamu alaikum, sir.
Walaikum assalam, Saiful. ভালো আছো?
স্যার, জি আলহামদুলিল্লাহ স্যার ভালো আছেন। আমি প্রথম থেকেই ছিলাম students. We are also students of you. Everybody will be very much benefited from this lecture in details. I think we should keep in mind during our clinical examination, because we saw several patients. The findings almost clinically same as mitral stenosis, like female patient, ill health, chronic cough, sometimes some sputum with hemoptysis, and also there is X-ray findings due to hemosiderosis and upper lobar diversion. So many things may mimic with mitral stenosis, and that is usually not in count with our cardiovascular department or cardiology department. So everything is nicely described by you. Just I want to give an emphasis for the clinical emphasis for differential diagnosis of mitral stenosis with other diseases, especially disease of the respiratory system. Thank you very much. And also thanks Dr. Mohsin and Professor Wadud to give me some take part of this wonderful
Thank you,
webinar.
sir. One question from Chayan Kumar, Dr. Chayan Kumar for BSc. Dr. Chayan,
Sir,
do you have me?
yes, sir. Sir, can you hear me, sir?
Yeah.
Nice presentation, sir. Sir, I have two questions. Why mitral stenosis is more common in the mitral valve? Number one question. Number two, when patient come with tachycardia, how will approach?
Okay. Why? Your first question, son.
Yes, sir.
I think your first.
Most common. Why most common?
Rheumatic heart disease.
Exactly.
Because exact mechanism or cause is not known, but there are some hypotheses. It is thought that mitral valve has to take the maximum stress, as it is a left-sided valve. Then falls on the mitral valve, and this is the cause. The mitral valve is involved in inflammatory process in case of acute rheumatic fever. And second question, your second question is?
Sir, a patient of mitral stenosis with atrial fibrillation comes to our emergency department with hypotension. How will control the rate and the